was going to say good morning, but I should correct that to good afternoon. And thank you very much, Graham, for inviting me to speak to you today. And Graham gave me the wonderful brief of, he said, talk generally about research, but you can talk on whatever you want to. So that's what I'm going to do today. And the title of my talk really says it all. I've chosen that title because some doctors and many lay people in New Zealand are confused about the risks posed to an individual by prostate cancer. And also I believe that the debate about PSA testing has diverted efforts away from work to reduce the damaging effects of the disease on New Zealand men and their families. Now I'd like to show you this table about prostate cancer statistics in New Zealand going back to 1980. First of all, if you look at the registrations column, you can see that numbers were around 1,300, 1,400 in 1985. They fell away dramatically in 1990, and that was because we were having some major difficulties with cancer registration in New Zealand. And there were issues about the confidentiality of data that meant that an awful lot of people were not being registered. And as a result of that, the Cancer Registry Act was passed in 1983, which made registration of all new cancers compulsory. Now that, along with some other changes, had a quite dramatic effect on the 1995 data, which had gone up to basically 2,500 registrations. Now, unfortunately, it's not all due to much better registration of cancer. It's also due to some other changes that became widespread after 1990, and that's the PSA tests began to be much more widely used. And also, ultrasound-guided zonal prostate biopsies became a standard of making the diagnosis of prostate cancer. So we were diagnosing the disease with more confidence. PSA testing was leading us to do the biopsies more often. And if you had to guess what the contribution of PSA testing was to the 1995 data, you would perhaps think that maybe it was responsible for 500 extra cases of prostate cancer being diagnosed. And then if you jump on to 2010, where we've got 3,000 registrations, you can certainly attribute all those extra cases being due to PSA testing. So perhaps on a baseline of 2,000 registrations a year, PSA testing has added another 1,000 to that number. Now, just moving across to the deaths column, I put it as absolute deaths rather than death rates because you can understand the absolute numbers. And you can see that 1985 was the worst year for New Zealand, where we had 700 deaths. But since then, we've been sort of hovering around the 600 deaths per annum figure. So we haven't made an enormous amount of progress in terms of the absolute numbers of deaths. We have with death rates because we're looking at an aging population here. Now, this is some important data that's just about to be published at the beginning of next month in terms of how are we doing with PSA testing compared to Australia. And if we look back to 1996-97, we diagnosed about 20 more cases of prostate cancer per 100,000 men than Australia did. And then 10 years further on, in 2006-07, we diagnosed 30 less cases. And really that huge shift or reversal of 50 cases of prostate cancer per 100,000 men can only mean that in Australia they're doing a lot more PSA testing than we are here. And for whatever reason, Australian men and women, and we do recognise that women often encourage their men to go and have a PSA test, they certainly seem to recognise the value of the test more than the average New Zealander. Now, I'd like to do what they do in that American program called Mythbusters, because I think there's an awful lot of nonsense spoken about prostate cancer that actually is sort of holding back progress with research into the disease, and particularly making a real impact on prostate cancer mortality. Now, the first thing is that in 2010, roughly 5 times as many men were diagnosed with prostate cancer as died of it. This means that prostate cancer will only kill 20% of men diagnosed with the disease. Now, that could be right, but it also could be wrong. And the reason for that is that the patients being diagnosed with prostate cancer now are going to die sometime into the future. And if you're diagnosed with localized disease at the moment, most of the deaths are going to occur after 15 years of follow-up. And even if you have metastatic cancer presentation, it takes 5 years before you're likely to die of the disease. So the truth of the matter is we need to wait many years to discover the mortality rate for men diagnosed and treated today. Death from prostate cancer occurs mainly in the elderly and is not a bad way to go. I have heard people say this to me, and I'm believing it to be true. And as you've already heard from John Charles, prostate cancer that has spread severely reduces the quality of life of affected men. And you need many interventions to palliate the symptoms. You know, from a health service perspective, it's an incredibly expensive disease to treat because of all these interventions. But also prostate cancer mortality is responsible for many premature deaths. And given that the average life expectancy of a man today is 80 years, I'm talking about men who die before the age of 80 years because of prostate cancer. Many men die with prostate cancer rather than of prostate cancer, and this is evidence that the disease has little impact on affected men. Well, about half of all men dying with prostate cancer will have metastatic disease, and many of these will experience the distressing symptoms that John Charles talked to you about. So dying with the disease isn't really much consolation to the people affected. Some prostate cancers don't progress and can be considered benign. This is, this is a serious error, and I talk a lot to my pathology friend Brett Delahunt, who actually is in the office next door to me, so it's very easy to talk to him. Cancers are never benign. They always progress. But of course, with prostate cancer, some of them do progress very slowly. And that's where the dilemma comes, is how quickly will the cancer progress. This is another serious error that's made by people. If I develop a prostate cancer that needs treatment, then I will develop warning urinary symptoms that alert me to its presence. There's data around that shows that this is complete nonsense. A trial that was done in Australia and New Zealand for the treatment of locally advanced prostate cancer got a lot of baseline urinary symptoms from the patients. That's before they'd had any treatment. And only 7% of those patients had urinary symptoms that they thought were of concern. So most people, even with locally advanced prostate cancer will not get urinary symptoms. Prostate cancer is diagnosed as a result of PSA testing rarely require treatment. Now, PSA testing brings forward the diagnosis of prostate cancer by about 10 years over symptomatic presentation. And that means that if you're 70 years old at the time that you're diagnosed, you're pretty likely to get symptoms in your lifetime if your cancer's not treated. So, you know, the bottom line would be most cancers diagnosed in men aged 70 years or less usually need to be treated. Now, there are exceptions to that, but that's the general rule. A 70-year-old man diagnosed with prostate cancer is unlikely to be troubled by the cancer in his lifetime. Actually, about half of 70-year-old men will develop symptoms from their prostate cancer in their lifetime if it's left untreated. And 38% of men will die of the disease. So it's still a threatening disease to people who are 70 years old. PSA testing leads to the unnecessary treatment of many men with prostate cancer. This is absolute nonsense, and a recent Australian series of 2,000 men, which will be aware to many people in this room, showed that only 5% of these cases had disease that might be considered insignificant due to the very small amount of cancer present or a low Gleason score. Now, it's also fair to say that that 5% were predominantly the younger men in the series, where the rules for insignificance may be quite different to those for older men. So very little over-treatment is actually taking place in Australasia at the moment. We have no reason to believe that we're doing any worse than Australia. In fact, we're probably more conservative here than the Australians. PSA testing should be avoided because the survival advantages are too small to justify the risks of prostate biopsy and possible unnecessary treatment. Now, cancers that have spread at the time of diagnosis are incurable, as John has already alerted us to, and PSA testing reduces the risk of this presentation by 50%. That's an enormous therapeutic gain. I mean, there's no treatment that ever produces a 50% advantage. So that's very important. And the other thing is the diagnosis before spread has occurred means the man has, first of all, a very high chance of having his cancer cured, but also he's got treatment options that are lost once he presents with metastatic disease. I would just briefly like to talk about the treatment options. Radical prostatectomy already been talked about in some detail, and we might describe it as the original gold standard treatment. External beam radiotherapy, there have been some huge recent advances in the accuracy and sparing of normal tissues with this treatment. And it's really unrecognizable from the treatment that I delivered 30 years ago. It's now very precise. We can direct it at a moving target, and there's much less radiation delivered to the bowel. The third option is this brachytherapy option, something called iodine-125 seed implantation. And that's a way of delivering extremely localized radiation treatment, so there are fewer side effects on the normal tissues. I want to say just a little bit more about this treatment because some of you may not have heard about it. It's been around for a number of years now. It was first described in 1983. It's a minimally invasive treatment. It has very high cure rates for early cancers, and we've just published our results in a European journal on the first 500 patients who were treated in Wellington. It's also notable for a very quick recovery after the treatment. The urinary side effects are generally very mild, and there's a low incidence of sexual side effects. Now that's the PSA control graph for these 500 patients. And for the low-risk patients, at 5 years, there's a 95% PSA control rate. And it's just a fraction below 90% for the intermediate risk patients. So that's very good control rates. And people who haven't seen one of these implants, that's what an X-ray looks like. Something like 100 little seeds are positioned throughout the prostate gland. And those seeds stay there forever. They're non-irritative to the tissues, so that you can live with those for the rest of your life. Now, just going back to prostate cancer mortality, a question that I'm often asked is, how did men dying of prostate cancer in 2010 originally present? Now, in an ideal world, the cancer registry should give us this information. If you have the clinical stage of a cancer presentation, then you know whether it's spread or not. But a best informed guess is that out of 600 deaths, 2/3 would have had evidence of spread at the time of diagnosis. And these are the people who are dying today. And 1/3 would have had disease that appeared to be confined to the prostate cancer gland at the time of diagnosis. Now that gives us some guidance as to how we should direct our research trying to reduce prostate cancer mortality. We certainly, with these people who are presenting with metastatic disease, we do need trials of new treatments. Obviously, we'd like treatments that actually cure the patient rather than just cause remissions. But if you look at how we can make much bigger gains, more PSA testing of men aged 50 to 70 years has the potential for much, much bigger gains than better treatments. Because a cancer diagnosed while still localized is usually cured. So we need as well to develop new strategies to reduce the metabolic side effects of long-term androgen deprivation. And I'm pleased to inform you that actually the solution seems to be really quite easy. That when you take away the testosterone driver of metabolism, everything slows down in your body. But you can, if you maintain regular exercise programs, you can actually lift your metabolic rate to something close to normal. And this has been shown by some work that's gone on in Perth, which I've been involved with. Now, better treatments have already been developed for people with high-risk cancers. And when we talk about high risk, we mean that they're likely to have invisible spread of the cancer. You can't see it with the tests that we have available at the moment, but the statistics say that it will develop in time. There was a TROG trial 9601, and TROG stands for the Trans-Tasman Radiation Oncology Group, which added hormone treatment to external beam radiotherapy and showed this reduced 10-year cancer mortality by 50%. Now that's a pretty substantial gain as well. Now, looking at the lower risk cancers, those that are unlikely to have invisible spread, we're unlikely that new treatments for these cancers are going to impact on prostate cancer mortality, because we have cure rates that are sort of up in the 90% range already, and sort of getting much improvement on that is difficult with new strategies. Now, this is a difficult group of men. The management is difficult because, first of all men, when they're diagnosed with a cancer, have an expectation that treatment will be recommended. Many of these men will not develop symptoms from their cancer in their lifetime, and this is what we mean by overdiagnosis of a disease. Overdiagnosis means that you discover a condition that is not going to cause clinical problems. And then, of course, overdiagnosis potentially leads to overtreatment. The other thing about older patients is the side effects of any radical treatment escalate with advancing age. And it's often thought that this is a characteristic that relates just to surgery, but in fact it doesn't. It very much relates to radiation change. And we're talking about radiation change in the normal tissues that definitely accelerate in older patients who have undergone changes in their tissues due to the aging process. So the next question is, well, which of these patients do need treatment? Most of the men in this group will have disease that remains localized for the duration of their life. And of course, we don't need to treat these patients. And a smaller proportion of men will have a cancer that spreads sooner rather than later as it grows bigger. These men do require treatment. And at the moment, we use Gleason's score and the PSA level of diagnosis to give us some clue as to which of the patients require treatment. But really, we need new markers of metastatic potential. And I want to tell you just very quickly about a research study that has been going on as a collaboration between Otago and Victoria University since 2008, where we've been looking for protein markers in samples of prostate cancer that predict whether or not the cancer will spread. Now, we've been using samples of cancer from patients where we already know the outcome, and these are patients on clinical trials that have been performed in Australia and New Zealand. And so in a way, we're looking backwards on patients and seeing whether we could have found out more at the beginning. And this is a very good collaboration with Bill Jordan, is really the New Zealand premier proteomics expert, and he's got an important place in the World Proteome organisation project. Sorry. Now, the good news is that we do think we've found such a protein. On a relatively small sample of men, it seems to predict very accurately whether or not the cancer will spread. We're now doing the work on a much bigger sample of patients, and at the end of that, we think that we'll be able to say whether measurement of the protein has a part in clinical decision making. I mean, obviously, the nice thing that could potentially happen would be that we with older men who present with prostate cancer, we measure the level of this protein and say whether or not they need treatment with confidence, and that would be a significant move forward. And it's important to say that the Prostate Cancer Foundation was really responsible for this research getting underway. Jonathan Dunn, who's the first author of the publication was the Prostate Cancer Foundation Research Fellow. And without your support, we wouldn't have got this work going at all. Nearly there. This is just to show you the I don't know why, there was a picture on, yeah, it's come up, that's good. First of all, the picture showing the two-dimensional electrophoresis on the left-hand side shows you how you can, you've got a pool of total proteins produced by a cancer cell, and you can, each of those little dots represents a separate protein. And we found 314 different proteins in the prostate cancer samples. And we've narrowed that down to one that seems to be important. And I just want to say something about the mass spectrometry and how you can measure the amounts of protein. The technology in this area has again leapt ahead over the last 10 years. You used to be able to, you used to have to run tests overnight that they took so long to give you the answer. So you set the machine working and then you come in the morning and see what it said. Now you get pretty well instant answers on multiple samples, and so the technology is very much available to turn this into a routine laboratory test. So just going back to the beginning, what's the answer to the question posed in the title to my talk? First of all, trivial problem. Yes, it can be, but only if the cancer is picked up at an early stage before it is spread, or the cancer is slow growing and develops later in life. Lethal disease? Well, statistics don't lie. 600 New Zealanders dying of this disease every year is, in my book, too many. And we owe it to not just ourselves, but our generations to come to bring this figure down. Thank you.